So very good afternoon, everybody. Respected panelists on the dais. I have been instructed by the organizers to keep this session as brief as possible, but we know that private sector's engagement is something which we really need to discuss a lot also. But I will try to be as brief as possible, and I also request all the panelists to be as brief as possible in this entire context. Right. So we know the context. Like India has done tremendous efforts in engaging the private sector generally. We also know that more than 50% of the people with TB symptoms are seeking care from the private sector generally. So lots of initiatives have been done by India. If you look at the performance main stage. But here we are going to discuss something different. We are going to discuss something different. We're going to discuss this entire session based on the multi-sectoral accountability framework. The word was accountability. Accountability framework. What is the accountability of the private sector in ending TB? Right? So when we think about the health system, we think only about the public health system. Is there a health system in the private sector? This is something which we also need to do. Is it worth strengthening that system? Is it worth giving a systemic architecture to that system? Will that help the NTP managers to coordinate well? Will that help the country to end TB really well? This is something which we are trying to discuss, and we have seen we have an eminent set of panelists who are actually sitting here. I am not wasting any time. We have Dr. Vinay Garg from the Central TB Division here. So, Dr. Vinay Garg, we know that we have done so much of things for the private sector engagement happening in India, and what are the expectations from the private sector? I mean, we are facing so many challenges also. Could you just tell us about what are the challenges that we actually face for ensuring private sector standards of TB care to the people coming in the private sector? Standards of TB care is basically the standards that every citizen should receive, right? That's what. What are the challenges as an NTP program manager we face, and what are the expectations from the private sector? Over to you, Dr. Vinay.
Thank you, Dr. Rakesh. This is a very pertinent topic for all of us, including program managers and population. As Dr. Rakesh told, initially 50% of the patients seek care from the private sector. So there is no denying the fact that we cannot fight tuberculosis alone as a government system. So first thing I would like to reiterate here is the private sector, we are working hand in hand together in our fight towards tuberculosis. Whatever support, systemic, social, monetary, drug, logistics is there, the program is always ready to support the private sector in all these our endeavors. So what our expectations are not so much different what a patient expects from their doctor. So in quality of care, we have like from diagnostics to social support to treatment. So all these aspects, uh, I expect that the private sector doctors or the sector by itself also considers, so that the patient is able to receive whatever minimum has been prescribed or we have by mutual consultation agreed upon. So it, on the outside it appears that private sector only those would be going who are able to afford private sector because of the cost. But when we see in deeper details, a lot of people who are going to private sectors are really poor people. TB is a has been known to be for most of the people for poor man's disease. So the purpose of program is for engaging private sector is also to reduce the out of pocket expenditure. So how do we reduce the out of pocket expenditure? We offer them free diagnostics, we offer them free drugs, we offer them social and monetary benefits which the government has prescribed. For that, what we require as program managers, we require linkages. So linkages in terms, how will we link? Like first point of entry is nikshay. So all presumptives should be as fast as possible be enrolled on nikshay, so that we are able to offer through our systems, private sector coordinators what we have appointed, etc., so that the patient's out of pocket expenditure is reduced to whatever extent we can reduce. Also the benefits which a lot of time has been mentioned in the summit, like NPY benefits or food baskets to the contacts and families, etc. They will be available only when the system comes to not there is a case. So expectations from program are these, but we do understand that private sector has their limitations in terms of HR, in terms of technology, how would they enter those data, etc. So we are trying to establish sustainable bridges whereby which the private sector practitioners and the organizations are not overburdened. They are able to focus on the care, and we handhold them in our fight together towards tuberculosis.
Thank you so much, sir, for that vision. The vision of the program, if you clearly understand that every citizen in India should receive the standards of TB care according to the based on the provider of his or her choice. That's what the vision of the program is, and the program is actually trying to support. That every citizen in India should receive the standards of TB care. Standards of TB care in India means the standards for diagnosis, the standards for treatment, the standards for public health actions, the standard for social inclusions, everything. The program is actually trying to support to ensure that all citizens are receiving this care from the private sector. Dr. Sehgal, so I have heard the story of intensified case finding that is happening in your institute. Dr. Sehgal is the medical director of a private hospital in Delhi, right? He's the medical director of a private hospital in Delhi. Let us hear from Sehgal about the experiences of intensified case finding that is happening in a private hospital, right? Then let's ask Dr. Sehgal the questions. We would love to hear from you.
Thank you so much for inviting me for this panel. Very first thing which I would like to say is, as a clinician for last 35 years, I have traveled the journey where significant number of cases were being given therapeutic trials. That means we could not diagnose. So, and we suspected very, highly that he has tuberculosis, he or she, and we started anti-tubercular. To the times when I insist to all my staff that without any evidence, don't start treatment. This is how much we have traveled, and I think it's a very good time. Second thing, for tuberculosis, a lot of efforts were being made since 1962, when tuberculosis control programs were started as a TB center, and we could not make much difference. Though this is a treatable infection, and it is not very difficult to treat it completely. We then came to TB elimination programs, where also I remember a nodal officer was stationed at our hospital, and we were asked to report every case to that person, and that person was managing all the affairs. We didn't know beyond that we have to report, and beyond that what was happening, we were not part of it. It is only in 2020 that Pradhan Mantri announced this program of TB Mukt Bharat by 2025, 5 years ahead of what WHO had envisaged. Somehow, I think we were not finding success. And in 2022, a revised national TB elimination program was announced with some changes. And even then, I think though we were taking care of and reporting our cases, but not much was being done, to be honest. It is only in 2024, in April, that union stepped in, and they, through AHPI, they guided us that they would be interested in having our center as a step center. And that is when we started taking things seriously. And now what we are doing for STEP is basically all our patients who are coming to our OPD to begin with, they are being screened. Initially, they were being screened for 4 symptoms. Now a set of 10 symptoms have been told to us, which our coordinators or links, they are screening these patients. And whosoever is found to be suspected or is having any of the symptoms is referred to the concerned specialist, who evaluates, and if he suspects this cough can be tuberculosis, he investigates them accordingly. And such patients are put on the Nikshay portal. And if a diagnosis of tuberculosis comes out to be negative, we continue screening them and watching them for some time. And if they come out to be negative, we remove them from the portal. Other patients remain on the TB portal, and if infection is found to be positive, we treat them for tuberculosis as per the case, as whatever the case may be. And this is how our screening has been going on. We have the management. Under them we have 2 nodal officers, one for pediatrics and one for adults, and these are qualified doctors, postgraduates, followed by a TB coordinator. We have 2 TB coordinators. One is the ICN infection control nurse, and the other one is one of the coordinators who has been trained specifically to follow this up, followed by everybody being declared as a link. The X-ray department, the pharmacy, the lab, anybody who finds a TB case reports back for reporting on the Nikshay Mitra. And this coordinator will coordinate with the patients, with the different agencies, even with the government agencies if a patient needs help. And very meticulously, we are trying to follow all these patients, help all these patients, even with the schemes, benefit schemes that the government is offering at the moment. And I think this way we are really doing justice. It is not very difficult, not out of the way effort, and things are very easily running in the streamline. And if I would like to give you data from 11th January to 5th March. 11th Jan is when we started this intensified 100-day program. We have screened 11,535 patients, and 480 patients out of them were suspected. 480 were put on the Nikshay portal. MAN2 was done in 16 patients. Gene expert was done in 64 patients. Positive were 11 and negative were 53. One was MDR and one is being treated for latent TB. So, I mean, as a matter of fact, I was thinking today that why don't we start a study for a small private hospital in comparison to large hospitals and national data, that what is the incidence that we are finding, how we are able to cope up, and what are the kind of results that we are able to give. Because the ratio is almost a little less than the national ratio, 1:1,000. And I am sure by forming such step centers, a consortium, which I am sure Dr. Khetrapal, who is the director in AHPI, and he has been helping us to take that activity ahead. We can involve the community, because along with this screening, we have also screened our hospital staff, then the family members of the hospital staff, and we've had 4 camps outside the hospital in Jhuggi Jhompri cluster and RWA, where these patients are being screened, and that is being done with the help of a QR code. The QR code has 10 features in it, and rest of the data of the patient, the phone number, the name, and this data is captured with us, with our nurse and coordinator, and she then follows them up. So this can be taken on a larger level.
Thank you, Dr. Sehgal. I just want to clarify again. You are saying everything is happening. We have heard the story. Everything is happening inside a private hospital, right? They have screened how many, sir? You said, say number
11,535
people who are coming to the hospital. They are
2 months.
They are screening intensified. Like every patient is coming, they are looking for TB using a QR code. They're asking for 10 symptoms. So that's why, based on the guidelines given by the National TB Program, they are doing. Is there any staff appointed by the government in your hospital?
No one.
Okay, you are doing it by yourself.
We are doing it. Actually, my ICN infection control nurse, Kushbu, is right here, who's managing as a coordinator.
Okay, so what is your motive?
See, I think the motive always is not money.
Okay.
Once I was, can I tell a small story? Once I had gone to visit some place where all my friends, they climbed up the stairs of a mandir. I sat outside and they asked me, why don't you want to come in? I said, I consider work as my puja. And if I do my work honestly, I don't need to go inside to pray. So that's I think the
Understood.
motive. And
Understood.
after 35 years of doing medicine, all my dreams otherwise have been met. Why shouldn't I give something back to the society?
Understood, sir. So everything is happening inside a. This is accountability. Basically saying private sector is assuming accountability to ensure standards of TB care to all the clients reaching them. Right. So they are not waiting for government to give them money. They are not waiting for government. They are not asking for anything, but they are saying that, okay, we are in this fight against TB with the government. Right. All the clients reaching us, we will ensure the standards of TB care. We will do intensified case finding in the private hospital. Right. Now we have Dr. Sunil Khetrapal, the director of Association of Healthcare Providers of India. Right. Association of Healthcare Providers of India, we are seeing in recent times, they are trying to organize the private sector. They're a huge network of private hospitals, which Dr. Khetrapal will be telling. Dr. Khetrapal, we have seen that you are organizing private hospital consortiums. You are trying to organize them. You are advocating with many hospitals for starting facilities like what Sehgal, Dr. Sehgal has actually mentioned, and making them accountable, making them part of this journey, and be an equal partner along with the public health system. Right? We would love to hear that story, Dr. Khetrapal.
Yeah, thank you, ICMR, and thank you, the union, for inviting me to this very important panel discussion. First of all, I would like to introduce my organization to all of you. AHPI is Association of Healthcare Providers India. It is a not-for-profit organization, and we are 12 years old, and we represent majority of private hospitals in the country. We have a strength of about more than 15,000 private hospitals with us as our members. And our main forte is we do advocacy work with the government, with the regulators, with the stakeholders. Largely, we work for the benefit of the society. And our main objective is that every citizen of the country should achieve universal health coverage that is accessible, affordable, and quality care. So in those lines, now I'm coming to this our role in TB space. So we have been working in the TB space for the last 3 years, closely hand in hand with the union. And AHPI, we launched AHPI End TB initiative almost 2 years back. And under this AHPI End TB initiative, we have started conducting various activities like workshops, webinars, and also 26 hospitals, our corporate hospital, they took that corporate pledge, TB pledge. And finally we decided that, as Dr. Vinay mentioned in his opening remarks, that 50% is catered by the private sector, and they want us and we want them. It's public private partnership, otherwise we cannot achieve our mission. So we thought of engaging all the hospitals under in one platform. So what we did, we we thought that we should form some consortium, and a regional consortium and a national consortium. So with this thought, we formed state consortium in UP, in Haryana, and in Delhi, where we engaged all the hospitals to come together and work and have the same approach towards TB care, because it was a very unorganized, in a very organized way which was happening. There were a lot of challenges by the private sector, but they have a major role to play. So we thought it is as Dr. Rakesh also mentioned, that we made ourselves accountable. So AHPI made itself accountable to work closely in hand with the union and with its members to support the nation's TB elimination effort. So STEPS is one initiative, system for TB elimination in private sector, which is a single window system, low cost and patient centric. So all activities are happening, end-to-end process happening in that STEP center. And of course, we have always got the support from the union in the training on the steps, and then we thought that this is something very good, that because with the implementation of steps, we will be able to implement the standard STCI, standard TB care. So Because quality of care is very important. It's not that everybody, is working, should work on its whims and fancies. So we should have a unified approach. Then we formed consortiums, and another thing, we formed a national consortium. Within 2 months of time, we formed 3 regional consortium and 1 national consortium. Just to tell you about the AHPI model, we are present pan India. We have 20 state chapters we have created. In each state, like we have a Karnataka state chapter of AHPI, we have AHPI UP chapter, AHPI Kerala chapter. That way we have created 20 state chapters, but we are present pan India. Like Northeast, we have 2 chapters, Northeast 1 and Northeast 2, covering entire 8 states of Northeast. Like we have Maharashtra and Goa 1 chapter. So Punjab, J&K and Himachal 1 chapter as a North, AHPI North chapter. So we are covering entire country, and in each chapter we have an empowered executive committee, because health is a state subject. Because they have to, but then we are advocating all these activities, the intervention steps and all, to our members. So this has really worked very well, I'm telling you. And people have not only, you can see the commitment, they have taken pledge. Even the DTG, even Dr. Sanjay Mattu was there during the physically present at the national consortium, which happened in Kochi on 30th of January this year. And he was part of this taking pledge, and I read out the pledge. So it was all our national presidents, state president and secretaries and executive committee members were there. Dr. Narin Sehgal is one of them. He happens to be the secretary of our AHPI Delhi chapter, very active. And because being in Delhi, he has an advantage. We are in Delhi centrally. We are guiding to all the states. So I went. He said we want to do something on 100 days intensified campaign. You launch it next day. Within 24 hours, we made it and we launched it. And we took all staff were there. They took pledge, and there were representation from the union, from WHO, from the state, from the district. So this is a passion. You can see how the movement we are taking it as a movement. It's not that just we have to support it. It is 20. See, the burden is 25-26% of the whole world's TB population is in India with us. So until and unless we all unite under one umbrella and have a common vision and follow the standard treatment guidelines, implement the STEP systems, we will not be able to achieve. So these systems are working very well. Of course, there are some challenges, but then in spite of some challenges, we are actually going ahead. And as Dr. Narin Sehgal has given some, his impact, I would not say the data he has presented, he has given the impact. In fact, it is an impact documentation which he has just mentioned. So we are collecting this impact documentation from our members, from the hospitals, from the regional and national level. So I think this is something. So much. I feel so much contented, and I'm leading this project from my organization, that is AHPI, as a country director. So this is something very passionate to us, very close to our heart, and we are always we will continue to support this to achieve the target. I mean, whatever the target is, it is our effort should be on. And we have to, not looking back or not looking behind. And Central TB Division is always with us. We have formed all this consortium under their guidance with the technical support from the union. So I think it is something which is working well, and we hope that it will, achieve.
So thank you so much, Dr. Khetrapal, for this leadership that you have actually playing. So you understood what Dr. Khetrapal is trying to say is they're trying to organize the private sector, trying to form in the form of a consortiums. This consortiums includes the medical directors or the owners of the private hospitals. They are coming together in each city. So I have attended a few of those. In each city, when we went to Haryana, all the private hospital owners, they are coming together, forming a consortium and saying, we will support the national TB program. We will ensure that all the clients reaching our hospitals, we will ensure standards of TB care. Right? This is what they are ensuring. We have heard how the Dr. Sehgal is doing that in his hospital. Right? Similarly, all hospitals are doing that. And this is not the model where we pay to the private sector and purchase the services. This is not that. This is where the private sector is assuming the accountability, say it's our responsibility we will ensure that all our clients are getting their correct. There is also a hidden interest in this one. This is basically an after-sale service model too. Why we want to engage private sector? We are engaging private sector for saying that, okay, because people are getting lost to follow up in the private sector. They are not getting the standards. We tell them lost to follow up. The program manager, Dr. Vinay Garg, tell lost to follow up. Dr. Sehgal, no, it's not only loss to follow up, it's a business loss to me also. From a private sector point of view, it's a business loss. My client is gone, right? So what Dr. Sehgal is doing, all the hospitals are doing, making a few phone calls, getting their clients back. Yeah. Making a few phone calls and getting their clients back to their system. What is happening? Client is completing the treatment. What is happening? The clients are completing the treatment. So there is no loss to follow up for Dr. Vinay Garg. For Sehgal, his business comes back also. Right. This is the model where there is no other financial transactions between government and private, but there is an accountability also in one. Everybody is.
I think this is probably the very unique model in the whole world. Probably, I don't know. I think you will have to say that this is something very unique. This model, which the approach which we have taken,
changing the perspectives of how we generally looked at this entire scenario is basically trying to change and organizing the sector. That's what they are saying. There is a system that is being built in basically. Currently, it's for the hospitals. That's what I understood. Right. Fine. We have colleague from. Let us see similar kind of systems running elsewhere also. Like in Indonesia, we have a colleague from Indonesia, Dr. Artawan. Artawan is from Indonesia. Let us hear from Dr. Artawan. In Indonesia, also we have heard similar kind of efforts to organize the private sector in terms of your external systems, internal systems, right? So what is that efforts to organize the private sector in Indonesia? Can you tell something brief about that?
Okay, thank you very much, Dr. Rakesh. I would like to say thank you very much for this great opportunity to share our experience from Indonesia regarding, we call in Indonesia, DPPM, District-Based Public-Private Mix. This is how to involve private sector in Indonesia on TB control program. This is based on the data that patient with TB symptom in Indonesia, 74% first time they will came to private sector. So we must engage the private sector first to increase the case finding and also the accelerate the case finding in Indonesia. We call this is district-based public-private mix because under the coordination of district or city health office. Start with mapping all health facility in the area based on public health center in Indonesia. And we start engage the potential private health facility, private hospital, private clinic, public hospital. What is the difference with public health center? Public clinic is belong to the army and the police also, and also laboratory clinic. This is laboratory is very important because there is a lot of medical checkup. Migrant worker of Indonesia, hearts, do the chest X-ray and IGRA test also. That's very potential to case finding, and of course, private practitioner. Including general practitioner and the specialist. We mapping and give the access of the private sector for the standard TB services. Start with the screening and diagnosis, access to rapid diagnosis test, and also provide the system information to report TB, presumptive TB and TB case that they find. At the first, we face a struggle when we provide a level of contribution. The first contribution is presumptive finding. The second is until diagnosis, and the last is until treatment and reporting. But at the first, most of the private health facility choose the easier one, is the only presumptive finding and refer to the laboratory for diagnostic. So for now, we also provide the capacity. There is no more choice like that. All primary healthcare, including private healthcare, must competent to TB services, to standard TB services. So we also develop a e-learning platform to improve their capacity, and also refresher training or hands-on training for the TB officer for data imputation to our surveillance system. This is part of the external network that Dr. Rakesh already say. The DPPM in Indonesia, the model is external network, the network between health facility and the internal network. Internal network mean every polyclinic must be contribute on TB case finding. For example, there are hospital have surgery, polyclinic, pediatrician, of course, ophthalmologist, radiology, and medical checkup also must screen for TB for their patient. Yeah. So not only responsible to the pulmonologist, because TB can occur in all organ except teeth and nail. Yeah. So mass polyclinic must contribute, because sometimes elderly who for cataract operation, for pre-operation, for chest X-ray, there are abnormality. Hearts examination, there are chest X-ray. Also sometimes without symptom found abnormality suggestive for TB, and so many cases like that. So they must report every patient that have TB presumptive. So the DPPM model in Indonesia is make the TB is everybody business. So all of the polyclinic must evaluate for TB, make TB everybody business, and nobody miss for TB evaluation. Yeah. So that's why in the last 3 years, the district-based public-private MIC Indonesia contribute a substantial effect on our case finding. We reached the 90% target of TB infection estimated. Yeah. For example, even the TB infection estimation in Indonesia increased 1,092,000 in 2024. We can reach at the last validation at the January is 884,000 and still counted, still validated. So we believe this is part of to strengthen the TB services in the private sector.
Thank you, Artawan, for explaining about how Indonesia is trying to organize sectors. Like there are, like we are all talking about a system, right? We started with the system, and what is the structure of the private sector in which that system can actually be put into. This is what we are actually trying to say, so that it is easy for the NTP to engage with the private sector. Now, what has happened is basically when I looked at with related 100-day campaign, when the Honorable DDG called a meeting. Now they are actually talking to the private hospital consortium chairpersons. Haryana has a chairperson. Delhi has a chairperson. If you look at our medical college task force system in the NTP in India, there are chairpersons in that. To communicate to the medical colleges, we need to talk to the chairpersons. Similarly, private hospital consortium of Haryana, private hospital consortium of Ghaziabad, private hospital consortium of Kochi, the chairs are actually coming and talking to the DDG. It's easy for the program to communicate, and they are taking the responsibility and accountability for that. Similarly, we have heard from the Indonesia. Now let us hear from Medanta. Medanta Hospital is here with us. Dr. Ashish is representing the medical directorate of Medanta Hospital. We have heard only what is happening inside the hospital, right? Now let us hear the story of a hospital doing something actively for TB. Let us hear that story. Dr. Ashish.
I'm Dr. Ashish. I'm working in Medanta. So this is I can just tell you the journey, what we have faced. It was started in 2014, when Dr. Banali has started a pilot project at Rewari. So she used to went with a van, that is mobile van, which has a chest X-ray. Initially, we started this pilot project, reading the chest X-ray and diagnosing TB, because these were then sent to National Tuberculosis Program. In 2015, Dr. Trehan has a dialogue with Mr. Amitabh Bachchan and Ratan Tata. Then we started Mission TB Free Haryana. So we are working with Mission TB Free Haryana for last 10 years. And I think it is one of its own unique program which has been running for last 10 years. last year we have celebrated the 10th, you can say, anniversary of this program, and we have screened more than 10 lakh people in Haryana, and around 80,000 X-ray has been done. Among them, around, you can say, 8 to 10,000 cases has been diagnosed, and we have seen the impact of this work. Because what you are working, just if I used to say that we are going to peripheries with our van doing X-ray and then asking them to go for molecular testing like CB0 or TrueNAT, and after that diagnosing TB, and then sending them to tuberculosis elimination program or RNTCP. So this has reflected the, you can say, when they see the data of tuberculosis program, that where we have intervened with this system, the case notification has increased 3 times. This is the national data which has shown that with the intervention of our program, the case notification has increased, because our job was to see the X-ray, do the molecular testing, and send them to tuberculosis program. So in the last 10 years, we have done huge amount of these things, and I think more than 10 publications we have published through this journey most of the time. And I think when we started, we had one single van which used to go to Rewari or one place with a X-ray. Now we have 5 vans which are working, and we have, I think, covered almost all districts of Haryana. And last one van we have sent to Delhi, where we have found we have done targeted, just doctor was telling, targeted population like Pusta, or you can say slum areas, and we found that the prevalence of TB at that stage was 6% around. And in our data, we have seen that this TB is still persisting, and we have to do more and more. So only just screening, doing X-ray and doing molecular test and then sending them to a tuberculosis program, we think we have to do more and more from our side.
Thank you so much. So we have heard what Medanta is actually doing, right? So being a private hospitals, they are actually going into the community, mobilizing money from various sources, not from the government, but from various sources, and screening the community. The hospital has gone outside. Generally, the private hospital will have only setups inside. Right now, the hospital has gone outside to the community and trying to screen. That's the commitment that we have actually screened. We have Dr. Vijayasree Yellappa here. Dr. Vijayasree Yellappa is the vice chair of the Global TB Partnership Group also, Public-Private Mix Group also. Dr. Vijayasree, you have heard all the stories that is happening and different ways of thinking that is happening in various sectors, and how private sector is assuming the accountability, coming forward to fight against TB. And there is a change in the perspectives also, how we look at the PPM generally. Now, as a PPM vice chair, for the National Strategy Plan of India, what do you think that India needs to do more, or how do you see this from your point of view?
First of all, let me thank you for inviting me for this panel, very interesting panel discussion. And my heart is filled with joy after listening to all of you. My journey with the RNTCP started in 2003, when we used to go to every private practitioner, used to explain what is RNTCP is all about, and look at the journey where we have reached, where the private hospitals have taken the ownership. My heart is really filled with joy. Having said that, I would reiterate Dr. Putra's statement that TB elimination is everybody's business. It is not only the mandate of NTEP, it's everybody's business. This agenda of TB elimination requires a clear commitment from the entire health system. Let's forget about private sector and public sector. Let's look at it from the perspective of a health system. And this commitment should start from the primary healthcare providers to the policymakers, to the insurers, to the innovators. And I believe we have come a long way in this PPM journey, public-private mix journey. Because TB elimination, I believe, is not a disease priority. It is entirely health system responsibility. So in this summit, Dr. Rajesh, I was thinking that, there are 3 important stakeholders. One is innovators. I think organizers have done a wonderful work of gathering all these innovators, and the private sector and the public sector. I have 2 plea for the innovators. As Dr. Sehgal said, and the president of AHPI was mentioning, Indian private sector is messy. It's complex. Why I say messy is that it starts from individual solo practitioners to highly specialized hospitals. And then you have chain of laboratories with different capacities and different sizes. And then you have numerous retail private pharmacists. And we know very well that both in rural and urban settings, they are the pharmacists at the first point of care. I've been thinking and I've been talking to the different program managers. Can we have a technology that would do a systematic landscape of the private sector? I would imagine a future DTO sitting at the district or at the block, at a single click, they should be visualize the complex private sector with the GPS coordinates. And then further, we should be able to have a AI-enabled tool to profile the private sector. So we should be able to see, okay, these are the private sector, these are the ones we need to prioritize. This will help definitely the managers to make a informed decision. TB PPM dashboards have been piloted in 7 high TB burden countries from the Global TB program. And Global Fund and other funders are keen on investing and implementing in other countries as well. India is one of the pilot countries, but it would be good to see this TB PPM dashboard, which is data-driven, real-time, to be implemented at district level and sub-district level as well. Coming to the public sector, I think, again, we have come a long way with the policy tweaking of engaging the private sector. But I have one concern which has been repeatedly heard from the field is some of the bottlenecks. Some of the people from Central TV Division who heavily participated in this PPSA is also there. This is about the contract mechanisms. Still, there are bottlenecks on how contract or how RFPs, request for proposals, are drafted. There is a need for capacity building within the public sector, how they float the RFPs, how they do the bidding. Here again, Dr. Rakesh, I feel there is an opportunity for AI and the technology based on your technical and financial credibility or criteria. The government should be able to quickly skim through the proposals objectively, no subjectivity involved. And also able to identify the most suitable private partner for this PPPs. And it is high time, looking at the funding sources draining up, we should also look at alternative funding mechanisms. Coming to the private sector, kudos again, the way the private sector has owned the program. But I think there are some work needs to be done from our end. When I say from our end, civil society, the CTD and the academic partners, I think we should be able to provide a platform for the private sector to influence the policies. They have the capacity. I will take 2 examples. Why shouldn't TB should be involved in an insurance package? Isn't it that policy, the private practitioners should push for this policy change? And second thing, I was also thinking of engaging with CII, NASCOM, FICCI, and influence the TB-friendly workplace policies. And also, why not tax incentives or tax-free treatments for TB-related health cost? So these were all some of the thoughts that I was thinking how private sector go beyond mere case notification, case detection. I think private sector has the capacity to influence the policy. I think we should start looking at the policy level, how private sector can really raise up to that. Having said that, involving the private sector is not an option. I think it is essential. If you have to eliminate TB, I think private sector engagement is crucial. Thank you.
Thank you Much, Dr. Vijayasree. All the suggestions which you mentioned has relevance. Starting from private sector is not homogeneous. Starting from indigenous practitioner, anything other than pulmonary, we call it extra pulmonary. So anything other than public, we call it private generally, right? So generally, it starts from indigenous provider to chemist to the lab to the individual practitioners to the Ayush practitioners to the corporate hospital. We call it as private hospitals. So we need to have a segmented approach. That's what you rightly tried to brought in. That's what we may not be able to reach out to each and every person because program has its own limitations or capacities. But see, an example is organization like AHPI. They have reached to the hospitals. Similarly, chemist associations, they might have reach. You have mentioned about other organizations, they have the reach. This is how we organize the private sector so that program can actually directly interact with them and trying to get them. So that has accountability of AHPI also we have seen, accountability of the individual hospitals also we have seen. This is something. You also mentioned about bringing in technologies for mapping and helping the program managers. Excellent thought process that you have actually brought in. You also thought about going beyond and contracting services, public purchase of strategies purchasing service in the private sector, and using AI tools for that. Brilliant thought process. The last point you mentioned is about the influencing the policies, private sector. National Consortium is an excellent opportunity which has the potential to influence the policies. What I have, when I listened to the National Consortium meetings where the Central TB Division was also there. Central TB Division was the secretariat of the National Consortiums. It's like a national task force there. So the NABH CEO was also there in that consortium. They invited NABH CEO and made that TB is mandatory for the NABH accreditation, TB ensuring standards of TB care services. Similarly, insurance companies they can call, pharma companies they can call. So they are the huge players, right? So they can actually influence. The National Consortium can influence. Maybe Dr. Khetrapal, just a minute, you want to talk about how you want to influence the policies?
Well, I think one thing you just mentioned about the NABH, and we have also spoken to the National Accreditation Board for Hospitals and Healthcare Providers, NABH, about this. This to ensure that that they are incorporated in the standards, that standard treatment guidelines for tuberculosis. So that work is going on. This will definitely improve the standard of TB care in India. And secondly, I think how AHPI can influence the policy is something we see. We have a strength and we have a major role to play. Our role is very crucial, and we have the reach, we have the members, we have 15,000-20,000 hospitals with us. So I think with the unified approach, we have been advocating actually with the government already on this. So I think our role as a unified approach and ensuring and that standard treatment guidelines will be followed by all the members. I think that's something
you're influencing the policy of the hospitals also.
Of the hospitals, yeah, absolutely.
Okay. So right, great,
yeah,
great. Thank you so much. I mean, it's time for us to conclude. But before concluding, I would like to ask everybody for their concluding remarks in a minute. Then I will finally give to Dr. Vinay Garg for the final concluding remarks. We'll start from Dr. Sehgal. What is your concluding remarks?
Yeah, two things. Very first thing, personally, ma'am, I think we need to encourage the private sector, and let's not call it messy. It can be unregulated, but not messy. That's the first thing. And second thing, you see, in the recent past, in our lifetime, the biggest infection that this world has faced was COVID. And India did beautifully in COVID. See how things were managed, and we all felt we had fear, but we felt safe that whatever is required is being done. I think that's the kind of, and that's the level of approach we need to have for tuberculosis also, because it is a treatable, curable condition. That's it.
Agreed, sir. Thank you so much for that comments. Dr. Artawan.
Okay, thank you, Dr. Rakesh. This is what that I say when I deliver coach in the coaching program for our colleagues in Indonesia. That I say provide services in high burden country. You cannot escape with TB patient. TB patient, like or not dislike, they will come to your clinic, and you cannot protect yourself from TB. No one will save from TB until everyone is safe. So you must contribute. Yeah.
Agreed. Dr. Ashish.
I think most important thing among all this program, which is my take home message, is the consistency. So we have been running this program for 10 years. That is most important. If you start anything, giving supplement, anything what you are doing, so consistency is most important, and follow up. That is my take home.
Great, great. Dr. Vijayasree.
I feel there is still a lot to be done in the kind of the way we are reaching out to the private sector. We should do more.
Yeah.
And I think the private sector, considering its reach and visibility, should sponsor in high impact media campaign featuring celebrities. You have the capacity to do that, and especially focusing on stigma.
Right. So what Vijayasree is trying to say is program has difficulty in reaching to the private sector. What Dr. Khetrapal is saying is private sector is coming to bring and meet the program at that level. So these two need to coincide at some point. And that's basically movements are happening from both the sectors. That's what we have actually seen here. Dr. Vinay Garg, you have heard all these conversations now. Over to your remarks.
Thank you, Dr. Rakesh. You have wonderfully steered and summarized what the comments were being made by the esteemed panelists. So it's very heartening to know that, and it's very joyful to me personally that hospitals, private sector, as sir said, they are making intramurally those steps, systems which has been implemented across the country, and quite a few of hospitals have taken intramurally as well as extramurally, as Dr. Ashish told for Medanta they have been doing. So that is really heartening that people are taking up, the private sector is taking up it as their own responsibility. It is not that it is being forced upon that. And the associations which Dr. Khetrapal would be representing, there are a lot of small standalone clinics, sir. So they are resource constrained. We all know that the one person sitting there, one pharmacist, one more person. So if through your organizations we can sensitize them, okay, if you are not able to do by themselves, a system we develop that they bring in through notifications, and the system can intervene and go to a certain extent only. Like we cannot approach all millions of private practitioners. Through the bridge between the organizations like yours, we can talk to them and we can ensure whatever is expected from the program side. I would say the program is what? Program is for the welfare of the patient. The benefits which the government is trying to give, they can be made available in terms of care, in terms of diagnostic, social support, monetary support, etc., can be made available only when we interact. So organizations like yours can be a bridge by which we can talk. So the most important thing is that, so standalone efforts like Medanta maybe can afford that kind of outreach, is able to do, not all hospitals can do. So that is what I would see is more and more interactions and bridges are formed. And madam's suggestion like targeted approach to what, like profiling of private practitioners, that's one thing which I would pass on to the concerned officer or the people who are looking at, that if they are profiled according to what the kind of population they are catering to and what amount of tuberculosis they are detecting, so we can have probably more focused and more yield given the kind of efforts we are having and the resources we are having. So that's point well taken. Overall, I'm quite hopeful that together with private sector we'll be able to make a big impact. Thank you so much.
We know that there are lots of questions to be answered, asked by the audience also, but we'll continue the conversations just outside this corridor because we are being called for the valedictory session happening in the other hall in another 5 minutes. So we need to conclude this session. So we'll be continuing the conversations during while we travel to the other hall also, during the valedictory session and during our lunchtime also. So I need to conclude this session now. I'm really extremely thankful this entire set of panelists sitting here. All the conversations that we had is being video recorded, that will be uploaded in the ICMR channel, will be made available throughout, and rapporteurs are sitting here and taking notes of these sessions. Everything is going to come up as recommendations of this innovation summit too, and is going to help to the key stakeholders are two people. One is National Strategy Plan of India, other one is for ICMR, what is in that. So that's how the entire sessions are being planned, entire discussions are being captured also in that way. That is going to happen in this way. Thank you so much for the eminent panelists. What we are actually seeing is basically organizing the private sector is happening at one end. Huge efforts has been taken by the India for engaging with the private sector through multiple various mechanisms. While the government is doing that systems through all the available mechanisms, private sector is also moving forward to the government and saying that we are also ready to join in this fight, taking accountability, expecting nothing. But we know that it's our responsibility as a part of quality, as a part of ensuring standards of TB care, as a part of accreditations. It's our responsibility to engage in the private sector. Also, the national consortiums, the policy forming bodies like Dr. Vijayasree has mentioned, influencing the policies like insurance, influencing the pharma companies, influencing the accreditation bodies. All these things are actually happening. While at the same time, the private hospital management is doing that. Organizations like IMA, IAP are also helping in mobilizing individual practitioners and through a coalition of support. That's how the ideal model that we are actually looking forward. Thank you so much. I am stopping here. Thank you so much, all the eminent panelists sitting here. Over to the organizers.
Thank you, Dr. Rakesh, for organizing it.
So I am the organizer also here. So let me request for the mementos. I will distribute to the panelists. Yes, sir, please.
Oh, yeah.
Thank you so much. So valedictory session is happening in the next hall number 90. Lunch is available at the usual place. Who has not seen the exhibition, go run and see, because we are going to close the exhibition. Lunch is happening there. Have the lunch. Valedictory session is starting now in the hall number 90.
Yeah, yeah. Sure.